This is Dr. Russell Blaylock, and you're listening to the Blaylock Health Channel. In this week's podcast, I want to talk about the subject of medical information, what you as a patient understand when your doctor discusses things with it. For instance, when we visit our personal physician, what we expect to hear from him or her is the best information available concerning our illness or their treatment. We do not expect to learn that our physician is unfamiliar with our problem or is uncertain, particularly if they're uncertain as what to do about our particular problem. In essence, we're looking for some degree of certainty. But just how certain is the medical information we're being given? Connected with this topic also is being fully informed by the physician. Now, one of the central tenets of law concerning medical care is what is referred to as informed consent. That is, you expect to be told not only the expected results of your treatment, but also all the possible side effects and complications that could occur. The law considers this reasonable, and it is reasonable. These two connected issues are the topic of today's podcast. You may find a good deal of the terms I'm going to use unfamiliar. Don't let that discourage you. Also, I'd suggest that before you continue to listen to this podcast, get a pencil and paper and write some of these numbers and things down. It'll help you visualize the concepts. Now, to begin with, let us take a hypothetical case. First, let's suppose you're a 30-year-old woman who appears in the doctor's office, and this is your yearly exam. Now, she's generally healthy, has no family history of any disease, especially breast cancer. Her physician, without any prompting, tells her that she needs to get her annual mammogram. And then he boldly states that a mammogram is 90% accurate in diagnosing breast cancer. She gets the mammogram done, and to her dismay, it's positive. The question she faces is, does she indeed have breast cancer? And is what the doctor told her true? That is, that she has a 90% chance of having breast cancer now that her mammogram has come back positive. The confusion, both to the patient and her doctor, is this 90% statistical number accurate? What we actually know from our studies is that for a person that we already know has a breast cancer, the mammogram is indeed 90% accurate in diagnosing it. The problem is that if you do such an exam on 100 healthy women, 9 of them will show up as positive, even though they don't have a breast cancer. We call these false positives. So 9% of women in her age group who have a mammogram will have a false positive test, but no cancer. Now, going back to our hypothetical lady again, we find that the likelihood of her really having a breast cancer is not 90%, but 10%. This is because out of 10 positive mammograms, only one of them really has a breast cancer, and 1 in 10 is 10%. If we turn things around, we see that the vast majority of women who test positive for breast cancer, most of them are free of all breast cancer. That is, 90% will be found to have no breast cancer, even though their test was read as positive. Now, for women having a mammogram between ages 40 and 50 years of age, the probability of one of these women having a breast cancer is 0.8%. That is not even 1%. The possibility that her mammogram will still be positive is 7%. In other words, over 7 times greater false positives than truly positive tests. Before we go further, we need to understand why both doctors and patients are confused about these statistics. And I'd also refer you to a wonderful book written by Dr. Gardasil, a psychologist who specializes in the study of decision-making. He wrote a book called Calculating Risk, and he works at Max Planck Institute for Human Development in Germany. And this book is a real eye-opener and should be read by both patients and physicians. Now, within the medical literature and medical books, information concerning the benefits of various types of treatment and risk are presented in one of three ways. The first way is what we call absolute risk. Now, this method works with absolute numbers of people involved. For example, it measures the proportion of patients who will die without a particular treatment, that is, the placebo-given patients, minus those who die that are taking the treatment. If, for example, we look at a study of a particular statin cholesterol-lowering drug called pravastatin, the study found that the number of people who died getting only a placebo was 41 people out of 1,000. Of those getting the statin drugs, 32 out of 1,000 died. The absolute risk was 9 out of 1,000 people. You subtract 41 deaths minus 32 deaths to get that number. Now, this in real terms is 0.9% risk reduction, not even 1% reduction in the risk for those who took the statin drug. That is less than 1% of all the people who took this statin drug avoided death. Now, looking at it another way, that means 99% of people who took the statin drug received no benefit whatsoever. Now, the second way of looking at statistics is called the relative risk reduction. Now, this is the favorite method of people that are selling something, a treatment or a diagnostic test. Now, here we compute the percentage change. For example, we take the absolute risk reduction in actual numbers, that is 9 patients that we used in the previous example, and divide it by the proportion of patients who died without treatment. In this example, 9 is divided by 41. If we do that, we get 22% difference. Now, this gives us a large number that sounds a lot more impressive than the 0.9% benefit. This is the number used by the pharmaceutical companies, physicians, textbooks, journal articles, and government organizations to make you think that this is a very important benefit. So you're getting 22% lower risk of death if you take the statins than if you don't. But in actual numbers, you reduce the incidence of death by only 0.9%, less than 1%. By doing this, it sells ideas and treatments. If, as a physician, I were to tell you that should you take this expensive, dangerous statin drug that I'm proposing to you, your chances of avoiding a heart attack is 0.9%, most likely you would decline the offer. But if I told you the benefit would be that it would reduce your risk of death 22%, you're more likely to take it. Now, the third method of presenting these numbers is what we call numbers to treat. Now, this method also is not very popular with pharmaceutical companies, government health organizations, and others that are selling treatments and diagnostic tests. In this method, what we do, we estimate the risk by telling you how many people we would have to treat in order to save one patient. For example, I would tell you I need to give the drug I'm proposing to 999 people before one would benefit. That's not very impressive. There's a joke that's told that when a physician advised a father that 1 in 10,000 children will experience a serious reaction from a vaccine, his response was, "Well, what number are you on now?" Now, if we go back to our mammogram example and we look at actual numbers, 8 of every 1,000 women will have breast cancer. Of these 8 women that have breast cancer, 7 will have a positive mammogram. In other words, that's where we get this 90% accuracy of the mammogram. But of the 992 women without breast cancer, 70 will be told that they have a positive mammogram because of the false positives. Looking at another way, of the 77 women having a positive mammogram, only 7 will actually have breast cancer. Now, in his book, he asked a group of 48 German physicians, all well-trained, highly experienced physicians, to determine the risk of a patient having a positive mammogram, the example I gave you. Only 2 out of 48 physicians got the right answer. A similar test was given to American physicians, and 95% got the wrong answer. On average, their estimates were 10 times higher than reality. Now, let's just go through what you're told by official medical sources. One of the things you constantly hear, particularly women going to their physicians or reading pamphlets and stuff by charitable organizations, is that mammogram screening reduces the risk of a woman dying by 25%. Now, when a large number of women were asked what this number meant, most said that if of 100 women, 25 lives would be saved. In other words, 25%. That's what they had as a vision in their mind when they hear this reduction of death by 25%. Well, here are the real numbers based on women under age 50 being screened by mammogram for 10 years. Breast cancer deaths in women having the mammogram was 3 per 1,000 women screened. You can write that on your pad on the left-hand side. Breast cancer death in women not getting a mammogram was 4 per 1,000 women screened. Put that on the right-hand side. That is, there was 1 less death per 1,000 women screened as a difference in those two figures. Yet mathematically, that's a 25% reduction. The absolute risk reduction would actually be 0.1% reduction. 0.1% reduction. That's not very impressive. So that's why they don't use the actual numbers when they discuss this with women. They want them to think that it's much greater than that. If, as a physician, I had to tell a female patient that the number of deaths prevented by 10 years of mammograms was 1 per 1,000 women would be saved, or 0.1%, most likely she would not be impressed enough to get her yearly mammogram. But if I told her screening reduced deaths from breast cancer by 25%, she probably would. Most studies have shown no reduction in death in women under age 50 by regular mammogram screening, as I discussed in the previous podcast. So what about women older than age 50, where most of the real breast cancers occur? Now, in 8 out of 10 randomized clinical trials, these are large trials looking at large numbers of women, screened for 7 to 9 years with a mammogram, found little or no benefit from the mammogram. 3 of these studies found a significant reduction in deaths. 5 of the studies found slight or no reduction in death from breast cancer. Now, knowing this information would hurt mammogram screening business, they simply pooled all the data from all 10 of these randomized trials and used that relative risk trick to come up with a figure of 27% reduction in deaths in women, older women who were undergoing regular mammogram screening. But let's look at the actual numbers. The actual numbers they found was that for every 270 women screened, 1 life was saved, or 4 women in 1,000, a much smaller number. Now, let us look at the effect of all this screening in real terms. What is it resulting in? Well, the study in Germany found that some 3 to 4 million mammograms were being done every year, and of these, 300,000 were false positives. That is, women were told they had breast cancer, but they didn't. The 100,000 of those women underwent some kind of invasive surgical procedure, such as a biopsy. Now, in the United States, some 50 million women get a mammogram every year. Millions of them have false positive tests, and over 300,000 of these women will have surgical procedures because of this false positive test. The vast majority of these so-called breast cancers are, in fact, carcinoma in situ, as which we learned before from the previous podcast. 80% of these will not lead to death and will not produce a cancerous tumor. Ironically, these women are being told that they do have breast cancer and that the mammogram saved them from a horrible death, particularly these charitable organizations collecting money for this campaign to find a cure. In fact, most of what is being found by the mammogram, particularly in the younger women, is essentially benign tumors, but it's taking credit for having prevented them from dying of breast cancer. So what are the women who are correctly diagnosed? Isn't all this scanning really worth it, even to save 1 woman in 1,000? This assumes that 1 life could have been saved by the mammogram. Yet a large number of breast cancers occur between mammograms, and the mammograms that diagnose breast cancer frequently do so only after the tumor is invaded already or metastasized, meaning it will not save the person's life. We also have to consider the risk of the radiation, which can be substantial for women starting mammograms at age 25 or 30. Just how many women are developing breast cancer caused by the mammogram itself is not entirely clear, but it's accepted that mammograms cause about 1% to 3% increase in breast cancer per year. Now, over 10 years, that can be 10% to 30% increase in absolute terms, and that could be responsible for more than one woman dying per 1,000 mammograms. It's probably much higher than that. Now, another way to frighten women is to tell them that they have a 1 in 10 chance of developing breast cancer, which is a common figure thrown around by breast cancer awareness groups and these charities, as well as by physicians. But is it true? Well, yes and no. It is true that if a woman lives to be 85 years of age, that sometimes in her life, usually after age 65, she may develop a breast cancer. Yet most people question about this number 1 in 10 assume it means at any time in life or within 10 years. That would mean that if you looked at 1,000 women, 100 of them would develop breast cancer within 10 years. But that's not true. Now, once again, let's look at actual numbers. Of 1,000 women aged 85 years of age, 7 died of breast cancer. Yet at the same group, 427 died of other causes, half of which were cardiovascular diseases. So only 7 died of breast cancer. The vast majority were dying of something else. That is, an 85-year-old woman is 61 times more likely to die of heart disease or stroke than breast cancer. Even at age 65 to age 69, which is the higher risk age, only 4 in 1,000 women died of breast cancer, and 52 per 1,000 died of other causes. A woman is 13 times more likely to die of something else than breast cancer. The majority of women in the older age group did not die of their breast cancer even when it was diagnosed. Now, another thing women hear from their doctors is that taking female replacement hormones increases their risk of getting and dying from breast cancer. They're warned, don't take female hormones, it'll increase your risk of breast cancer. But is that really true? Well, it's true for synthetic hormones used by the traditional physician. Yet even then, the actual risk is overblown. Women who take replacement estrogen hormones for 10 years, only 6 women will develop breast cancer above the normal incidence. This is a 0.6% increased risk, not even a 1% increased risk. What these women are not told is that hormone replacement reduces colorectal cancer risk in half. Almost as many women die of colorectal cancer as die from breast cancer. Now, what I hope I've been able to convey to you in today's broadcast is that you must be very careful in believing what you're being told by medical authorities, disease charities, and government agencies. Billions in profits are being made by selling drugs, special diagnostic testing, and other procedures. And these sales depend on scaring people, and they do that using statistical manipulation of data from studies that seem to support this fear message. A good example of this is selling of vaccines. For example, we're told that millions die of hepatitis B every year, and that's why all people must be vaccinated. They fail to mention that the United States has the lowest incidence of hepatitis B in the world. And 90% of people who are infected with hepatitis B, the infection will clear spontaneously without any treatment. Most of the deaths from hepatitis B occur in third world countries. They use the same tactic to sell the HPV vaccine, the Gardasil. They fail to inform the public that 90% of cases, that is 90% of women infected with HPV, the infection will clear spontaneously without any treatment, and that the real cause of cervical cancer is inflammation. In the 10% who have persistent infection, the cervix becomes inflamed over a long period, and this causes the cancer, not the virus directly. There's considerable evidence that poor hygiene and multiple infections are necessary to cause cervical cancer. Also, they fail to mention that most cases of HPV-induced cervical cancer occur in women after age 40, and the vaccine given to a young girl is no longer effective when she reaches the real age of risk. So the lesson today is you need to be very careful believing things as they're presented. You need to look at the more accurate numbers, and then you get a real picture of your risk. If you enjoyed listening to this week's podcast and would like to hear previous episodes of the Blaylock Health Channel, go to our website at www.blaylockhealthchannel.com. Thank you. The information contained within these programs is not intended to replace or contradict that of your physician. This information is for educational purposes only.